minute or two. As you know, the National Symposium is a themed symposium that changes every year. We're very happy that sometimes non-glamorous, non-refractive, non-cataract topics like childhood blindness also make it to the National Symposium. We're very grateful to AIOS. And just to strengthen that resolve, the chairperson of our National Symposium is none other than the president of the AIOS, and he's going to be joining us soon. But until then, I'd like to invite on stage our co-chairman, Professor Sudarshan Kokar, if you're here, Dr. Subhadra Jalali, who will be moderating, and Dr. A.K. Mandal. And none of these people actually require any introductions. They are giants in their field, and we'll be sort of going with you on some of these topics that are of national interest, especially for the general ophthalmologists. The speakers, we have in all 7 speakers, 7 talks. 6 of them will be 10 minutes each, and the last talk by our chairman, Dr. Santan Gopal, will be 15 minutes, and then he will round up the whole session with some summary and conclusions. The speakers will begin with the ROP talk. That will be myself, Anand Vinekar. Pediatric cataract surgeries, Dr. Sudarshan Kokar. Childhood glaucoma, Dr. Anil Mandal. Pediatric refractive error correction, Dr. Meenakshi Swaminathan. Ma'am, can you join us as well? Please. Dr. Kokar is here. Please, sir, please come. Myopia in children by Dr. A.R. Banerjee, and decision making in strabismus surgery by Dr. Gopal. Okay. So in the interest of time, we will begin. Dr. Gopal, I'm sure, is held up in another session, and he'll join us soon. So I'm going to begin with the ROP segment, what every ophthalmologist should know about ROP after the Supreme Court judgment. I have no commercial interest, but I'm the honorary member of the National Task Force for ROP. So let's begin with this controversial Supreme Court judgment. For a lot of us in the field of ROP, this has been a fillip. This was 1.38 crores slapped against a tertiary care government center in Chennai, Tamil Nadu, for a child who had turned blind because it was not screened on time. And this child was no longer a child when the judgment was given. Child is 18 years old. So the father has really fought it from the Consumer Court to the State High Court and gone to the Supreme Court. Within 6 months to 8 months from this hearing, 2 more cases were decided against the doctors. And one was against the ophthalmologist, and the other one was against the ophthalmologist pediatrician combined. One was in New Delhi, and the other one was in Indore. So suddenly we are seeing a lot of medical legal negligence cases against ROP, and we should be aware where our liabilities lie. The other thing that has happened recently in the past 2 or 3 years is that ROP has become a vertical program. And as they say, one blind child is a tragedy, but when there are millions, it just remains a statistic. So what are the statistics? We lead all the number of countries in the number of preterm babies born. We have 35 lakh babies. The incidence of ROP is anywhere between 38 and 52%. Treatment requiring ROP is almost 10%. And there are less than 100 ROP specialists across the country. We've recently started a society, so we are quite aware that the number is really acute. Also, in rural areas where babies were not surviving before, they're surviving now. So suddenly there is an increase in the at-risk babies. The third big problem is this hybrid ROP that has been reported from our country, from the PGI group, which shows that variable levels of neonatal care can actually worsen the situation. So you have vasoconstriction, constriction, dilatation, because the baby has been given improper oxygen protocols and then goes to a higher center, then they can't afford the higher center, they come back to a lower center, and this goes back and forth till you get very bad ROP that's difficult to treat. The next thing that has changed is that rather, this is an old myth that we still carry, that some of the senior pediatricians we deal with say that, you know what, we've never seen ROP blindness. And this study showed that they don't go to the pediatrician, they go to you and me, they go to different centers, they're hopping. And the other big change that has happened in the past decade is that rural ROP is showing its ugly face, and the incidence of ROP is as high in the rural areas, probably higher than the urban centers. In our Karnataka model, about now close to about 1 lakh babies, the rural incidence is 22%. So it's still less than the urban, but the treatment requiring is anywhere between 1.7 to 7.9%, depending on whether it's government or private clinics. So at least the best case practices that we have to be followed is the National Neonatology Foundation guidelines. Until the new version comes in 2016, was supposed to come in 2016, but it's going to be now. This is the one that is required to be seen, and let me summarize that. So it's no longer 1,500 grams as the Western literature, but it should be less than 2 kilos. So every baby born less than 2 kilos should be screened, or less than 34 weeks. This is sometimes expanded to 35. The first screening should be done definitely before 30 days of life, between the 3rd and 4th week in most cases, and babies who are born less than a kilo should be screened between 2 and 3 weeks of life. We did a small study in rural Karnataka, and we found that even if you screen a baby before discharge, that is, even if it's a few days old, even then it is worth doing it even though you're not expecting ROP, because the follow-up is so much better. So you don't really have to wait for the 3rd or 4th week, and you can screen it as early as a few days. This is the new guidelines that have not yet been released, but I just want to show you some glimpses that it has now become a vertical program. Government is now focusing on both primary prevention, secondary prevention, and tertiary prevention in all these. Again, it has summarized. These are busy slides, but it tells you the same thing. The other thing that is changing is imaging. Imaging is slowly being taken over as a viable alternative for indirect ophthalmoscopy. So that's where I want to share some of our personal experience. This is a report that was produced on our telemedicine program in Karnataka by the CDC guidelines. And, if you just read the second sentence, ROP screening is now a mandate, and suboptimal management can expose the government to medical legal liability. So it says that if you do indirect ophthalmoscopy that is not performed by adequately trained ophthalmologists, it's a medical legal liability. So this is where it is right now. Treatment, it's no longer we do threshold, we treat much earlier, we treat stage 2 with plus disease, we don't have to wait for stage 3 with plus disease. We can use the green laser, and this report showed that it is probably better than using the diode laser. So for anyone who's doing medical retina, you don't have to buy another laser like a diode. You can just use the one that you've been using. The treatment can be done in the rural areas itself. You don't have to get the babies to come into the center. You don't have to wait for the baby to become all right systemically, that is. You can treat even if the baby is so sick that it cannot be removed from the incubator. And finally, for everyone who wants to get into ROP treatment, the government is now reimbursing you. Whereas they are giving 1,500 rupees for diabetic retinopathy, they're giving up to 10,000 rupees for ROP laser, all sessions put together. And this is already in the government gazette. Of course, it's for each state to take different values. In Karnataka, we don't get 10, we get 8.5, but that's still some money when no money was coming for ROP treatment. Just want to touch upon some controversy of the anti-VEGF, because this is a lot of people are giving this without probably knowing its safety issues. So we do not recommend it at the National Task Force. There's a wonderful editorial written by Dr. Azad and Dr. Jalali in this IGO session and in this IGO edition. I just want to share with you what happens if you don't monitor these babies after giving injection. This is a very bad case of ROP where the blood vessels have not even crossed the macula. So we've given injection. You can see 72 hours, 4 days later, the plus disease is coming down, the blood vessels are going in the periphery, and it's doing well. So we know it does well, there's no doubt about that. But what you have to be very careful about is the way these things recur many, many weeks, in fact, sometimes months later. This one recurred almost 2.5 to 3 months later. And we've seen cases where people have injected these babies and they come to you with stage 5 ROP. So believe me, if you want to give injection, yes, do it by all means, but be aware of its consequences, its dosing, the follow-up schedule, and please document all of that and take a very detailed informed consent. What I'm trying to show you here is you have to go back and fill in, and in this case we did the laser after it recurred, and then it does well. Future directions. This is where the country is moving. In fact, the whole world is moving, middle-income countries especially. We are now saying that ROP screening need not be done by ROP specialists. In fact, need not even be done by technicians like our Karnataka model, but can be done by the NICU nurses. So we train NICU nurses to take pictures of these babies with low-cost cameras which are housed within the center itself, and they are uploaded to you or the ROP specialist, and you can come back on the report very live. And for that, there are some low-cost cameras in the market. I'm presenting this at another session, so I don't want to dwell well on it. But these cameras have still not reached the mark where they can replace the red cam, but they are a good screening tool, at least in the community where you're getting wide field images all the way up to the edge of the retina. But the big lacunae we still have is the lack of trained resources, human resources. I'm not talking ROP specialists here. I'm even talking about people who can take these pictures. So we've just started this wiserop.com, which is Wide Field Imaging in Screening and Education, and this is supported by the Indian ROP Society. You can visit this site. You can see a tutorial. What we're trying to do here is to bring some sort of objective guidelines on how how anyone can be trained to take good and validated images. And these have live video sessions where we can mentor the trainee imager to make him accredited. Finally, I want to introduce you to this Indian ROP Society. It was started just last year under the supervision of Dr. Azad. All of you all who are doing ROP work are welcome to be part of it. And finally, the blindness burden that you can prevent from ROP is unmatchable. And using the Blenkov formula, what we've done in Karnataka is almost 400 crores of blindness prevented if you multiply that by the per capita income and the life expectancy. And that's really the thanks that you look for when you're in the ROP business. Thank you very much. I welcome our chairman, Dr. Santan Gopal. Sir, wanted to thank you on behalf of everyone here for allowing a theme like pediatric and childhood blindness in this very prestigious Platinum Jubilee AIOS.
Thank you, Anand. First of all, my apologies for being late. It's just not possible to just run from one hall to the other because 100 people want to shake my hands and take selfies and all. So I get stopped in between. If I have very less time to come from one hall to the other, the hall gets delayed. I'm very sorry. I respect your time. Sudarshan.
All right.
Go on.
Dr. Santan and dignitaries on the dais and friends. I've been given a task to tell you guys about pediatric cataract surgery. So I'm going to stick to the surgery, no boring statistics, because I think everybody wants to see surgeries. Maybe it might not fit into the theme of the thing because it's a surgical thing, but I never liked the statistics anyway. So what its children become shall be the community becomes. So with these words, if you don't treat a child at that age, you need to have a person who goes with him everywhere he wants to go. So there are two people who are not able to work for the GDP of the country. So we'd like to operate a stitch in time will save you 9. So do it as soon as possible and as well as you can. So this is how the lens forms. It's a clear lens. So any time, any stage at any of this duration, if you have an insult, it reacts by the lens going opaque. So if it acts at a particular age, that lamella gets involved. That's why these are called the lamellar cataracts or zonular cataracts. Okay. So what you need is a good surgery, which is very simple. Follow-ups and compliance is the most difficult bit which you have to follow later on. A good anesthesia team is mandatory. So your basic concept of the surgery is to clear the media, to remove the scaffold at the back by doing a good vitrectomy so that you don't have the lens formation again, visual axis of specification. And if you're not very confident in putting the lens, please do not put the lens, but still clear the media and leave a support which you can use later on to go for the secondary IOL. So let's go ahead to the surgery straight away. So what are the things you're looking at? So these are the headings I'll cover the surgery with. The first and foremost important thing is these are not adults. So you can't ask this patient to move the head and come into the microscope and look into the light. Need to have rings which are the specific size of the rings. You need to have rings which are pediatric size, infant size, and adult size. So you have to have all the sets of rings which are available to you, which can be easily made. You can take rubber rings and put on the cotton fiber along that. And the speculums has to be all sizes available to you on the table. You can't shove in an adult speculum on this one, and the moment you enter the eye is going to collapse because the scleral rigidity is low. So you've got to be having specific and make sure the eye is looking into the microscope because he's not going to respond. And you saw I put something under the shoulder. You got a ring, the neck flexes, and put the shoulder thing under, and it extends again, and you got right end onto the microscopes. So that's what it should be. Incisions are always a 3-incision surgery. You can't do 2-incision surgery in pediatric age group because you can't reach 360 degrees all around. So you use your non-dominant hand, which in my case is the left hand. I make the left incision first. Then I make the right incision and then the main incision. I make all three together. In case you lose the chamber after making one, you can stop there and you can fill in the Visalon, Helon later on and go back to that again. You don't lose your sleep if you are not making all 3 incisions. Okay. So you got 3 incisions. Now what you need to do is you need to do a capsular cross linkage. I call it a cross linkage because the moment you put in Trafen blue, you put in a 1 in 10,000 adenine, which is intracardiac. It dilates the pupil for you. And then you put a stain. Stain is for demarcation. Even if the clear lenses do it because it makes the lens more it loses elasticity, so it becomes less elastic, and you can do a better rexis than these ones. So you got in a dye and wash the dye out from all the openings, so you have the marking of the incisions. So anytime you want to go in with a needle, you're not damaging the endothelium or the epithelium, searching for the incision. So that's how it should be at the end of the thing. So anterior capsule rexis, I think has to be about 5 millimeters. I am lucky to have a Callisto eye with me, so I have a microscope which tells me how much is a 5 millimeters, so I can go inside it. My geometry is not too good, but I think it's quite circular and it's inside the 5 zone, so I'm happy. So if you don't have that, you can use the old Trifines, about 5 millimeter size from the Dummer friends, or you can use the RK markers with the central marking, and you can go 5 millimeter. You can use any of these forceps. I think this slide is what you should remember. That's what is the anterior capsule, and that's the posterior capsule. For anterior capsule rexis, you have to push it down all the way. That means you have to overfill the chamber. Whereas for the posterior capsule rexis, you have to underfill. I'll come to that when I come to the posterior capsule. So you overfill the capsule and try to take out all the air out, which I'd put for Trifen Blue. And there shouldn't be any duality in the chamber. It should be one uniform bolus of Helon GV or Helon 5, whatever you fancy. So now I measured this. My central ring this lens was about 5 millimeters. So I'm going to just stay close to it, a plus minus 0.5 here and there. So I'm using Outrata forceps, because this is what I recommend all the beginners, that they should start with Outrata forceps and then switch over to the longer handle forceps or the intravitreal forceps. And you see, it's so simple. Thus, because I've filled up the bag well and my lens is pushed downwards. Otherwise, it will spiral out, and top of the hill phenomena, it will just go into spirals and go away. So we don't want the chamber to be lost. You see the chamber is well formed, and there you go. Right? It should be 5 millimeters to cover. So what about the longer forceps? Now see, I'm doing the same surgery with the longer forceps now. So see, my control is not very close to the incision. It's far away. You just notice I have 3 openings, so I'm using an intravitreal forceps, and I'm going around it. If I pull or push to any of the directions, it might just tear off. So with the intravitreal forceps, it takes a little longer for you to practice, but you can. It's something like eating the noodles with a fork or a chopstick. You can be expert with the chopsticks. I can manage with both. I can use the fork. I can use the chopsticks also. But in case you're not very good at that, you can stick to the Outrata forceps, which you are anyway used to in the adults. So once this rexis is complete. Now this is what I'm trying to tell you. See, the control is so good here. You could be clumsy in the beginning, but where you hold the forceps, where you hold the chopsticks, it make a difference. So with this slide, if you have in mind, even if you use the Outrata, you're not doing anything wrong, because anyway, you're going to suture this incision anyway. I have to rush through because my time is not too much. Then you do the hydro, multi-quadrant hydro is must. In these pediatrics, you please leave the viscoelastic inside the eye while you're doing the hydro, unlike in adults in which you take it out because you don't want the nucleus to go down. Because here the wave goes through the viscoelastic and keeping the chamber formed, cuts through the lens, which is a soft putty-like material. It's something like you cut it with a femto. It just goes like a wave all, and you can take it out. You can use a coaxial for taking the cortex out, or I've recently started using bimanual. The trick with bimanual is, by the bimanual, the one for which you have the blades of the same size. Now this is 23G bimanual and my incision is 23G, so there's no leak anywhere. Chamber is well formed, stable, and I'm going in and out, and it's just a cakewalk actually, if you have a good instruments in your hand. And the advantage of bimanual is, if the cortex is left on the other side, I'll skip a little faster. You can change your hands, go to the other side, and voila, you can just take out whatever you want. You can see the breathing pupil there, and this is the patient. Right, and it tells you that the scalicity is low and there's no leak. That's why the chamber goes deep. It tells you that your incisions are perfect, and that's how you can clear it up. So once you've done that, what about the posterior capsule? Till 7 years, I think we should do PCC in all these patients, and if the patient is mentally challenging and you think he's not going to sit on the slit lamp, has a head posture or problem, please do the PCC even for the kids which are more than that, because they won't be coming back to the YAG, because you don't have the vertical YAG, your horizontal YAGs. So what you do is, now, you see the picture again, because that's more important. Now you fill in the bag, not the bag, you fill in the anterior chamber with viscoelastic. Please do not put any viscoelastic here. I'm just going around and not pushing anything there. You don't want this lady to go back, because the posterior capsule, if you push it back, it becomes more concave, it goes further away from you. It becomes very difficult for you to do the rexis, and it will try to run off because there's a bolus of the Helon on the top, which is pushing the things down. But the procedure is the same. You come for the side port, make a nick, then you got a vertical nick there, and go straight in and hold it and keep grasping it again and again, and you go around 360. For the last 12 years, I never had the runoff of the posterior capsule, whereas the anterior capsule, I still managed to make it go off in 8 to 10% patients, especially when the viscoelastic leaks out of the eye. In the posterior one, please underfill and keep holding it. you're holding it so gentle as if you're putting on the green. You don't have to hold the putt very hard. If you hold it firmly, you might hit it too hard. So you've got to be gentle feather touch on that one, and that's how you go. Then you can use with the stain. I'll just take a minute more, please. And you do a vitrectomy, and the end point of the vitrectomy here is that when the capsule, posterior capsule which you made is the same shape which you had made. What I want to say is the vitreous gets hydrated the moment the fluid goes in, and it'll start coming out from the side, and your end point should be when you see it's distorted, it's getting distorted there. So you just a gentle sweep, cut it out, and cut it 2 millimeters all around the capsule, 360 degree, using both bimanual and a core vitrectomy. You're not supposed to go too posterior for that. That's just to take the scaffolding away. Okay, so lens implantation is important. Single piece lenses are meant for the bag. It should be put in the bag only. If you have a accident, you have a rent or something, please do not put the single piece into the anterior, in the sulcus, or please do not capture that. They're not meant for capturing. They're the job done for the 3-piece lens. So there's a technique of putting the lens with the donut open. So what we do is, now, I just got 2 slides now. So I fill in the donut with my viscoelastic. Now I got a posterior axis, I got anterior axis, I got done a vitrectomy. My donut is filled up. I enlarge the section. I don't use wound-assisted hair like adults. I don't want the cocoon of the lens to go in. I take the tip all the way and insert my lens into the bag. Now, what is the trick here? It's something like when the aeroplane lands, it doesn't touch the nose. It's going down, but when moment it wants to touch down, the rear wheel come down and the nose goes up. And that's what you should keep in your mind. And if you do that, you can put this lens even if your posterior capsule is not intact. Please do not try that without practice, but it can be done. Now, this is what I'm saying. Now, this is an acute entry. You got into the vitreous, right? We don't want that. This is too anterior. It's gone in front of the capsule. So this is a gentle touchdown. Your touchdown and your nose goes up into the bag and hits the posterior surface of the anterior capsule. So you're actually taking the strength from the posterior surface of the anterior capsule, and that's about it. And 3-piece lens can be put anywhere. You can do the capture. And the final slide is that you have to suture it up. Now, you can't leave this 2.2 millimeter incision or 2.3 millimeters incision because there might be a wound leak, a patient might cough, and next day you might not have OT available. So you have to suture it. So the trick there is to suture the main incision, and you can hydrate the side ports. Recently, I was operating in Australia in which they made me suture all the side ports also because they said the OT might not be available to us for 1 week. But if you follow the trick which we have just published, in which it's called the expanding bubble technique. So you put in a little bubble inside the eye, you suture the main incision, then you hydrate the side ports. You keep hydrating the side ports so that the bubble stays constant. The bubble should not expand. If the bubble expands, that means one of the wound is leaking and the aqueous is coming out and the bubble is coming anterior and it's expanding. You can use this for the adult surgeries also, right? So the kids can help you improve your surgery as adult also. So you see the bubble is stable. And if you want to remove this bubble, you can take it now because this chamber is sealed. This bubble by 24 hours is going to disappear and you can do a retinoscopy the next day without any problems. And that's what we do in all these patients. You give antibiotic, atropine in these patients, and that's about it. So if you remember this slide, I think my coming to this symposium is done. Thank you very much.
Thank you, sir. We're a little behind schedule, but while we're fixing the next speaker, if there's any quick question. Our next speaker will be Dr. Anil Mandal.
I had the video, but the lack of time, I don't know, but yes. But be careful, you wash it out properly. You might have a spike of the pressure in these patients later on. Otherwise, yes, it can use.
Dr. Mandal will talk about childhood glaucoma, 10 minutes.
Respected Chairman, sir, senior ophthalmologist, friends, ladies and gentlemen. The topic allotted to me is childhood glaucoma and the duration is 10 minutes. To respect time, I have included some videos and commentaries in it and timed my presentation. Childhood glaucoma is a rare disease, but it's a priority area for Vision 2020 because it accounts for 5% of childhood blindness. Now, recently, Glaucoma Research Network has been formed, and it's an international consortium of glaucoma specialists, including all countries of the world. And we came to know that the largest chunk of childhood glaucoma is primary congenital glaucoma. And hence my presentation, I'll confine my talk on this disease, primary congenital glaucoma. If we go back, say 70 years, it is said that future of children with congenital glaucoma is bleak. But recent advances in the management has improved the prognosis, as will be evidenced in few minutes. Genetic understanding has improved, which is beyond the scope of this presentation. Medical treatment has a limited role, and the surgery is the option for the management of primary congenital glaucoma. The surgical options starting from the year 1940 till date has been listed, and from the list, in our country, most of the patients we see is suitable for primary combined trabeculotomy and trabeculectomy. I have been trained by Professor N.N. Sood in the All India Institute of Medical Sciences, who published in 1983 and commented that primary combined trabeculotomy, trabeculectomy is very safe and effective in controlling intraocular pressure in Indian children we see. In the British Journal in 1994, an editorial say that primary combined trabeculotomy, trabeculectomy may represent the next step in the search for the best surgical treatment for congenital glaucoma. We analyzed our results of different aspects of primary and secondary developmental glaucoma. Here is a publication on primary developmental glaucoma, 15 years result, and here is the survival curve. Can you present this video? Just to tell about 21 years result, I have incorporated some commentary.
.653 consecutive children operated over a 20-year period by a single surgeon were analyzed. Kaplan-Meier survival analysis showed reduction in success rate over a period of time. Success rate of 93.4% at the end of second year decreased to 69.8% at the end of 10th year. Best spectacle corrected Snellen's visual acuity of 6/18 or better was achieved in 27.6% of the children, in whom operation was done for the first time by us, did relatively better compared to the children who underwent second surgery. Children in whom corneal clarity was normal did relatively better compared to the children who had corneal edema or corneal scar at presentation. Children who had congenital glaucoma at birth did relatively poorer compared to infantile and juvenile onset developmental glaucoma. A child presented to us with acute eye drops because of infantile glaucoma in the left eye was operated by the technique. 6 months postoperative appearance revealed total clearing of corneal edema of the left side.
Can you present the video? The surgical results shown in this slide, the surgical technique will be presented. Can you go back and present?
Compare and contrast.
Go back. Just the trabeculotomy part of the technique has been, next slide. Tap in the center.
A central radial incision is then made across the scleral spur. The objective of this radial incision is to cut the external wall of the Slem's canal and to avoid entering into the anterior chamber. This is the most delicate step of the operation and demands most microsurgical skill. The next step is to perform trabeculotomy on each side of the radial incision. Once 90% of the trabeculotome is within the canal, it is rotated into the anterior chamber, and the rotation is continued until approximately 75% of the probe length was entered into the chamber.
Next video, can you present the next video? The surgical result of the same patient.
Compare and contrast the appearance of the left cornea at presentation and at 2 weeks, 2 months and 6 months after the surgical technique. Note the clinical appearance of the HABS striae in this child.
Can you present the next video? So this is yet another example, and the HABS striae looks like this in the long run. Next, can you present the video? Go back, present the video. The surgical
Catching my gaze with limpid eyes, his mother's arms he refuses to see. With appealing eyes, he speaks the language of his soul. The faces lit up with smiles, a radiant beam on the baby's face. Each little one, not a patient, but like my own child does seem. These little gems are tomorrow's dreams. I cherish their budding beam.
You have seen the quality of life of the caregiver, which improved so significantly. I'm not going into this aspect. We developed a questionnaire for assessing the quality of life of the caregiver, and we also reported impact of surgery on the quality of life of caregiver, which gives significant improvement post-operatively. Here is a child operated at the age of 1 month. This is the appearance of the child. This is the condition of right and left eye to start with. And here is the 3 years post-operative appearance. Can you present the video? Here is the 5 years appearance of the child. Go back, present the video.
How do you feel today? How do you feel today?
Performing in the Children's Day celebration in 1 year. Next. Here is the child seen at 22 years of follow-up. The child is in, listen from the child about his, performance, what he is doing. Can you present the video? Go back. Present the video.
Anil, please remember that we are running short of time.
Yeah. So I'm just, you can leave the video, no problem. The slides are not coming. Can you present the last slide, last but one slide? So I just wanted to tell that just to an example, my operated congenital glaucoma child now studying 5th year MBBS in a medical college. Here is another child completed MBBS doing internship, and here is the appearance of one child whom we operated, and the child completed now about 6 years of follow-up. Thank you.
I think that deserves a big round of applause. So wonderful work combining both skill, passion, dedication, and wonderful follow-up. If you have a quick question while we invite our next speaker, Dr. Meenakshi Swaminathan, who's going to talk to us about pediatric refractive error correction.
You please ask Anil, he will show you any number of videos. He's a good man. He will send you videos also. Great job you are doing, Anil.
Good morning, everybody. The dignitaries on the dais, friends, I thank Dr. Santan Gopal for this kind invitation. And unlike the really very interesting talks before me, I do not have a single video, but I'm going to address a problem that all of us as general ophthalmologists or pediatric ophthalmologists must face every day, which is refractive errors in children. These are two siblings. The older one, the right bottom, started wearing minus glasses at about 7 years of age, progressed at the rate of 1 diopter a year, and progressively even developed an esotropia. So the mother brought the younger sibling. Yes, of course, he's also myopic, and now she is very concerned what's going to happen. This is not something unusual for us. Many of us face this every day. So what are the parental concerns? Parental concerns are as follows. Will this number increase? When can he or she stop wearing glasses? What can I do as a parent to prevent it from changing? Could we have picked this up earlier, doctor? There's a little bit of guilt that they feel. How much TV and mobile and tab and iPad and laptop my kid is permitted? So the objectives of my talk is to quickly cover the natural history of refractive errors in children so that you have some answers to give your parents, the current recommendations to retard myopia progression, screening for refractive errors, and screen time for children. So when we look at this paper, which looked at emmetropization in human infancy, they found that the high refractive errors, in their study they had no myopes, however, the high refractive errors of hyperopia and astigmatism they found in the infancy quickly regressed and they became emmetropic. A few more points about refractive errors. Normative things in children is mean refraction in the infant is +2, according to Banks from 1980 study. Hyperopia increases for 5 to 7 years and then starts tapering. Myopia typically starts increasing from about 8 years of age and goes on till about 13 or 14. Myopia, astigmatism, and anisometropia are more common in premature infants. So in other words, if you diagnose +4 hyperopia in a child who is 5 years old and your parent asks, is this number going to increase, doctor? You said, yes, it's possible that it may increase over the next few years, but then it starts tapering. But myopia is a completely different story. At the COMET trial, which is the correction of myopia evaluation trial, they found that the younger baseline age was the strongest factor independently associated with faster myopic progression. In other words, if your patient is a first grade child, 5 years old, and is already showing up -3 diopters, it's likely that this child is going to progress at a faster rate. So if the parent asks, you tell them, yes, it's possible that this minus is going to start climbing. So you follow all the preventive measures, which we are going to talk about in a minute. What about prediction of juvenile onset myopia? A less hyperopic and more myopic baseline refractive error was consistently associated with risk of myopia onset in multivariate models. This is what the study found. So in other words, if a child with a lot of parental myopia history and many risk factors is brought to you, say, at age 5 and is already plano, then you tell the parent to start cutting back on all the risk factors, because guess what? Your child may start becoming myopic very soon. So, looking at a study from our own country, Rohit Saxena and colleagues, which is called the NIM study, the North India Myopia Study. Now, this study showed that there was a positive association of presence of myopia in children studying or reading more than 5 hours per day. That's scary, because our school system talks about studies, and then they move on to tuitions. And so there is a lot of near work, a lot of studying happening in our kids. And look at this, positive association with watching television more than 2 hours per day and with playing computer, video, mobile games. Inverse association with outdoor activities and playing was observed with children playing more than 2 hours in a day. Which child of ours has time to play for more than 2 hours in a day? They're all with their books or with their mobile phones. Remember this, that is going to put them at a direct risk of increased myopia. So yet another study from Guangzhou showed that myopia risk factors are as follows: female gender, higher grade, longer time spent for near work, shorter distance of near work. You know, our grandparents used to always say, he's holding the books like this, isn't that harmful? He's lying in bed and studying like this, isn't that harmful? And the study actually showed, yes, it can be harmful. That is the closer working distance. And parental myopia were shown to be associated with increasing risk of myopia. So you have a family that walks in and both parents are wearing myopic glasses, and here is a child who is already showing at 5 years of age starting of myopia. You tell them, you know what, cut back on a lot of risk factors. Close the tab and the mobile and send your child outdoor to play. Now, The impact of parental history has been shown by many, many more studies. What about myopia progression? Now, this study was quite a landmark study, and our recommendation today is based on this study from Guangzhou of 6-year-old children, which showed that the addition of 40 minutes of outdoor activity at school compared with usual activity resulted in a reduced incidence rate of myopia over the next 3 years. Very important finding. So that it does make sense. In those days, they used to be asked to go out and play every evening, not go and sit in front of the television. So with this, there is a lot of public health awareness programs in countries like Singapore, Taiwan, and China, where myopia is a very big problem. So they have these posters everywhere which say, keep myopia at bay, go outdoors and play, and so on and so forth. More such posters. Okay, now you have diagnosed myopia, you have diagnosed progression. You as their ophthalmologist, the family's ophthalmologist, what are you going to do? When are you going to start intervening, and how? Who will you target treatment? So typically low levels of myopia, but if there is a younger age at onset, urban environment, the child is presenting less outdoor time, doing a lot of near work, shorter working distance, girls, though the Chinese ethnicity doesn't apply to us, but we may have, as we move to the eastern parts of India, and 1 or 2 myopic parents, then you usually treat even any levels of myopia. You start treating them to prevent progression. And what do we mean by treatment? There is pharmacological therapy available, and atropine 0.01%, which many of our pharmacies and hospitals will manufacture, even though it's not commercially available. There are other methods, spectacle-based contact lenses, and I'm into 24 months, choose high-quality programming, and you as a parent watch it together with the child. In older children, limit media to 1 hour or less per day. This is important not just for the eyes and myopia progression, but also for the cognitive development. No screens during meals and for 1 hour before bedtime. With that, I will invite you to many of the symposia that are coming up and meetings coming up in Shankar Nethralaya, the Cataract Catalyst, the Retina Summit, and the Shankar Nethralaya Glaucoma Meet. I thank you once again for this opportunity.
Meenakshi, for sticking to time. You are from strabismology, so you know how to be perfect. Good. Subhadra is going to talk on national guidelines for eye health checkups from birth to school. That's a wonderful talk. Subhadra, we need your help in reaching in social outreach program where we want to reach 1 million people in the next year or so. So we need all the help from you.
Thank you. That's what I'm looking for, and I just want to tell everybody that this talk is not only for your patients, but it is for your own children. Any newborn in your family needs an eye checkup, and we are not doing it. If you put your hands up, like how many of you checked your child's eye? You know, you had the health checkup of the child, but I have seen doctors and ophthalmologists and retina surgeons' children going blind because they didn't have an eye health checkup. Now that's very scary. So there's something which is for you, and not only for your patients, and it's not only for retina people. So the national guidelines have been cleared by Government of India and already published, and then talked about it little. But I want to say, like how much resources we want to allocate to the eye health check of our younger citizens. Are we going to talk about numbers, or are we going to talk of impact? So this child was the 10,000th child in my screening program, which is running since 1998. She was brought up in this swanky NICU in a village area, district hospital, which is one of the 700 which Government of India has set up in last 5 years with the help of national and international NGOs, including UNICEF, to attain what we call as the Sustainable Development Goals of reducing neonatal mortality. So India has a large number of children who are dying within 1 month of age. So to prevent those deaths, this child was one of those thousands of children which are now being saved in our rural areas. But at 3 months when she came to us, she was already blind. Remember, she was not born blind, and she was under health care. So why the knowledge from journals has not transferred to vision for this child? The information, knowledge that ROP will occur when an incubator is set up is known for more than 60 years now. And the treatment guidelines are more than 30 years. Everything is there in the journal. So why did this information and technology, which is not very high-tech, reach this child? So if you look at our data, we have put up this infogram for the parents, for the public, that ROP and all other childhood blindness are increasing. These are children who come to our hospital less than 10 years of age, and you can see over the last 10 years the numbers have increased. The numbers of vitamin A deficiency blind are decreasing, but congenital cataract, glaucoma and hereditary retinal diseases are almost same, except for a little increase because of increase in population. But the preterm babies who are coming are almost 15 times more now than what they were before. And not only that they are coming more, but that they require more intervention. And you can see now I am doing only pediatric retina surgeries. I have no time to do adult retina surgeries. So the Rashtriya Bal Swasthya Karyakram is a new initiative which is aimed at screening over 27 crore children from 0 to 18 years for 4 Ds. And these Ds are defects at birth, diseases, deficiencies, and developmental delays. So when this program was initially conceived, there were a lot of diseases, but not a single eye disease was put in the screening. We have diseases like alkaptonuria and maple syrup disease in that list, but there was no eye disease, and I was horrified. So a lot of us in the task force, we worked with Government of India. Now we are very happy that the operational guidelines included at least few eye diseases, and these diseases are labeled here: congenital cataract, ROP, vitamin A deficiency, and vision impairment. So vision impairment would cover most of the things, including, blindness. So what is envisaged and written in this document is that for newborns, all newborns will be screened for eye health, either in the hospital where they are born or by the ASHA worker for those children who are born at home. And they will continue to monitor their eye health and all other health 30 diseases parameters for birth defects till 6 weeks of age during their home visits. And after 6 weeks, these children will be encouraged to come to the Anganwadi, where a dedicated mobile health team from the district hospital will visit on a scheduled time, day of the week, and these children will be screened there for the next 6 years. And beyond 6 years, of course, this is already in place in many places, and it's being put in many places, the children's screening, eye screening in school screening programs. So now what we understand from the program is that who is going to screen these babies for eyes. Obviously, we who are busy cataract surgeons are not going to go to the nursery and screen 28 million children for their eye health. So it has to be done by the ANMs, by the medical officer, or by the gynecologist, whichever doctor is there, any basic doctor or health worker will do it. And the existing health service provider will be trained to detect, register, report, and refer these birth defect patients to the district hospitals and the district early intervention center. So we all in the audience can immediately recognize what is the challenge for us as ophthalmologists, that these people have no training. So they need to be trained on basic eye examination of newborns. Even we as ophthalmologists have not been trained in basic eye examination of newborn. So training and sensitization of the current staff and training, ongoing training for the new trainees. When the new trainees are coming, then it has to be in their curriculum, because we can't keep on training these people for next 100 years. So that is the challenge. The community-based newborn screening, which will be done from 0 to 6 weeks, will be done by ASHA workers. So these are just 12th pass people who are doing all the other health checkup. So they have to be trained to do a basic eye health checkup by simple tools for detecting gross birth defects, including congenital cataract and vision loss. And they have to be equipped with a pictorial reference book. So the health team which will visit the Anganwadi will have a medical officer, usually from AIOC, one male, one female with a bachelor's degree, ANM, a pharmacist, or an ophthalmic assistant who will do the data entry. So what we have done with the National Task Force is that we have prepared some pictures, and we are continuing to do that. And if you have some good pictures, we are happy to incorporate them, of the ASHA worker to learn how to ask the family history. Is there a history of any other child or parent or grandparent or cousin in your family who has eye problem? That child straight away goes for a detailed eye checkup to the district center. But if there's no family history of retinoblastoma or cataract or anything like that, then the ASHA worker does the basic examination with a torchlight, opens the eye and sees, is there an eye at all or not? Is it small? Is it big? Is there any obvious defect? So this is pictorially given and trained to them, because these things can be picked up with a torch. Glaucoma, corneal problem, anophthalmos, ulcer, small eye, big eye. So these things they can be taught because this is visual. And then they are also taught to do the red reflex test. Now nowadays, previously we were doing it with direct ophthalmoscope. Now it is being taught with a digital camera. Any digital camera or a cell phone camera can be used to check for the red glow at every visit. Then in the district hospital, they are going to set up, and already they have been set up in many places, early intervention centers. And in this center, we are very happy that they have put a post of an optometrist in these centers. So every center will have a full-time optometrist for vision screening and eye health screening. And then the program also says that every state should put in its annual implementation plan a budget for training, which the central government will give, and the cost of translation and printing of tools to train these workers and to make the awareness will be done. And from eye point of view, these are the centers which have been put up as the training collaborative centers, which will help other centers to develop and do the training. So all the top places are there. Then the state and union territories would conduct the mapping to identify the public health institutions. So this program is basically going to be run in government hospitals primarily, because they are the largest providers of healthcare in the rural areas, and private sector partnership and NGOs who do the specialized service, like suppose a congenital cataract surgery has to be done. So identification will be done in the public hospital, and they can have a tie-up with the tertiary care private hospital or an NGO under public-private partnership, and these will be reimbursed, as Anand already told. So what we have got now is 20,000 rupees for congenital cataract surgery and 10,000 rupees for lasers, and this is already sanctioned, and your state has to ask for that. So in our city, what we have done is map out all the hospitals which are there and make sure that the program is running in all the hospitals. We don't run that program. We empower the local ophthalmologist or the local ASHA worker, the local sister, to screen for some of these birth defects and train, and now we are also doing it for the other 3 states that we are there. The other thing which Anand already said is the skill enhancement of the eye specialist to detect and treat these diseases, because we don't have very good training of even mid-level personnel. So that work is also ongoing to train people to detect correctly, not miss findings, and how to screen. Please don't screen if you are not trained, because we do see people who are not trained trying to screen, and then it messes up the case. Or trying to put some homeopathic laser few spots, and then there's no laser spots when we see, and there's already a detachment. So it is good to take training, and then we are very happy that you treat. So what I have put here is that we need good manpower, infrastructure, materials and strategies. So what we want that every retina department which is having an ROP program, please train your fellows. So this is Biju Raju. Within 1 month of finishing his fellowship, he had the courage and the conviction and the skills to treat his own baby who was 800 grams and, safely come out and treat his own child. So that is what we want. It's not a difficult thing. If people can learn phaco or LASIK or, so many other difficult cataract surgeries or other surgeries, vitreoretinal surgeries, the laser treatment for ROP is a skill which can be picked up. Takes about 3 to 4 weeks for anybody who has done lasers in adults, and they can, treat their own child. There's no difficulty in doing that. So we are also putting up infrastructure so that we take care of children in our own center, and we don't have to rely on too many pediatric help when they are in critical care. And we are the first center, and I'm happy that RP Center has now also incorporated a pediatric center in their eye department so that the children can be taken care of. Of course, Anand also said some cameras. This is one of the cameras that we are trying to build, which can be used by anybody to take a picture of the retina and see what is there. The education is now happening in the government hospital, so that is what we, anticipate in the RBSK program, that the private hospitals which have a lot of expertise and some of the government hospitals which has a lot of expertise will trickle down that expertise to the district hospital, government hospitals. And we are very happy that in our city, Nilofer Hospital is the first hospital in whole of the country which has its own doctor, ophthalmologist there, its own laser machine, and its own indirect ophthalmoscope, and a trained person who is doing the treatment in the NICU of the hospital by themselves. And nobody from outside is coming, and we are now replicating it in 4 other hospitals in our city. So a lot of advocacy and awareness, public material programs is being done so that everybody accesses and knows what to do. And what do we expect? So sometimes people ask me that you're doing all this screening, and also what do these children see, especially ROP babies? So I just want to tell, just like it's a question like asking, if you give polio drops to all the children, will all the children walk? Yes, they will walk because you're doing a preventive program. And if a child doesn't walk, that means your prevention didn't work. So same way, if you have screened on time, treated on time, then 80 to 90% of your children will get 20/40 of vision.
You need to conclude,
yes,
please.
So that is the last slide I want to say. So let's go. This is from Samarth, that we need to move ahead and get to every child. And urgent agenda, this I have talked to Dr. Santan Gopal also, to AIOS also, that please start putting the curriculum in place for various health workers so that we are geared up to do this training. And I'm very optimistic, sir, because this year we are celebrating the 50th anniversary of smallpox eradication, and this bronze statues here, which is in front of the WHO office in Geneva, highlights that the smallpox eradication did not happen because of doctors. It happened because of the health workers and because of a small innovation of a double-pronged needle, which increased the efficacy of smallpox vaccine. And so that is what we need, good technology, primary health workers who are your foot soldiers, who have to be trained to do the eye screening, and then only we can rid of unnecessary childhood blindness. Thank you.
Thank you, Dr. Subhadra. We have 2 more talks before we conclude the symposium. Can I invite on stage Dr. A.R. Banerjee, who will speak to us about myopia in children, what every general ophthalmologist should know. So then in that case, we'll move to our final talk by Dr. Santan Gopal. He's going to talk about decision-making in strabismus surgery, aim to avoid over and under corrections. And sir, after your talk, I request you to summarize and wind up the session as well.
Okay. Good morning. I'll try to stick to time as far as possible. I didn't come on time because of the reasons I explained to you. Now, strabismus, whenever you take any decision, whether it's operating on a child with strabismus or child with cataract or demonetization for that matter, these decisions have to be planned in advance. That's one. Planned in advance, and you should take it to the final end. This is what I'm going to do if this happens, because nothing can be predicted in strabismus. Even the great Van Noorden said, "Will my eyes child be straight?" He said, to say that I need to be a god or a goddamn fool, and I'm neither, which applies even today to all. However, just because the strabismus surgery results are unpredictable doesn't mean that you do what you want. No. There are certain guidelines to follow. You follow the guidelines, the results will be as per your wishes. Now, when you look at a child like this or like this, or like this, and they want to make them look like this, and they want to make them look like this. Okay? It's not just your operation which makes them look like this. There is a planning going beyond your operation, which should come before the operation. And that planning is what gives the results like this. Okay? I'm sure Anil would have showed number of videos if he had some more time where he plans out his surgery in advance. Am I right? What needs to be done, what should be done. And you heard Subhadra talking about eye health checkup for children. So many factors you need to plan it out. If 10,000 children are in front of you and they are screaming, if you have not planned what to do, you will never do any work. So planning is essential before any work to be done properly. Okay? Now, I'm going to talk about how do you plan your strabismus surgery in children. Certain decisions have to be made, as I said, before you actually operate on the child. And these decisions are dependent on what is your goal? My goal is to bring out all the black money. Okay, I'll demonetize. I'll bring out black money. Simple. But how do I demonetize? All that planning should go on. How do I demonetize without telling anyone? Planning should go on. Same way, what is my goal? My goal is to achieve straight eyes. My goal is to achieve equal vision and binocular vision in the child. So if that is my goal, what do I do? Is it possible to achieve my goal in all patients at all times? Not necessarily, but don't lose your goal. Okay? Now, what factors you consider? One is family history of squint. Is there a family history of squint? Mother nods the head vigorously and says, nobody in the family has squints. And after this, she stops shaking it, the eye would have gone out like this. Like this. Okay? Because the parents would have said, my daughter, before marriage, the parents would have said, my daughter is perfect. And they would have sent the photograph. And the boy would have looked at the photograph, squint not recognizable, got married, and she has squint. And then the child develops squints. Within 6 months after birth, the child also has squint. So you ask the mother, she says, I never had squint. You ask the husband, says, I don't know whether she had the squint or not. I like her. With or without squint, I like her. So it doesn't matter. Okay, so family history of squint is essential. Age is important because at what age you want to operate. Somehow, the more I try to dispel the myth that you should operate on children over the age of 4 years only for exotropia. I end up seeing so many esotropes, they keep saying, don't do anything till the age of 4. I don't know how to stop this, the myth which has gone on in the minds of the people. It's a myth. Do not say this at all, to any child for that matter, that we will wait till the age of 4 years. It's not true. You should wait till the age of 4 years if you are not experienced, if you don't know what you are doing in cases of divergent squint which is intermittent. If you know what you are doing, even intermittent divergent squint, you can operate before the age of 4 years. I have done plenty of them. There is no issues at all. Esotropia, operate as soon as possible. There are various reasons why you should do that. We will not go into that. Okay? So if you say, should the squint be operated within 2 days, I say yes. It should be operated within 2 days of correct diagnosis. You see, every word is important. Should be operated? Yes, it should be operated, but with a perfect, correct diagnosis. What does it mean? It means that it involves a lot of factors which you take into consideration before you say yes. The reason is very simple. Now, single cortical cell potentials have shown that in the brain there are cells which respond to stimulation of both the eyes equally, right and left eye. They are truly binocular cells. Some binocular cells respond to right eye stimulation more than left eye stimulation. They are right dominant. And left eye stimulation stimulates some cells more. They are left dominant. And some cells are stimulated only by right eye and only by left eye. They are uniocular cells. These are the types of cells available in the brain. Kitten's brain, they have done experiments where they have shown the moment you occlude one eye, the moment you create squint in one eye, within 48 hours, the electrical potentials of all these binocular cells disappear in the brain. What does it mean? It means that immediate electrical derangement is taking place in the brain following either squint, following patching, following occlusion, etc. So should we now operate? This happens within 48 hours. You create squint, within 48 hours the brain electrical activity disappears. So what does it mean? The squint appears within 48 hours, at least the functional changes in the brain happen, if not the structural changes in the brain cells, which takes a long time for us to identify and recognize before doing anything at this current technology. But it will improve, and gradually functional MRI will become the norm, and then we will have the effect. Therefore, as I said, you must operate on squint as soon as possible. Don't delay it. Age at which, I have already told you, it should be before, not necessarily the age of 4 years, before the age of whatever time you diagnose, it should be operated, provided it is not before the age of 6 months. The earliest age I have operated on an esotropic child is 6 months. 5 months I have operated one esotropic child because of bimedial fibrosis. The child went to some big hospital, they said, nothing needs to be done, and they came to me, I said, we'll operate. And the child is doing perfectly well now because that was a congenital muscular fibrosis, which they misdiagnosed as esotropia, and I operated at the age of 5 months. So therefore, if you are sure, you operate. But if you are not sure, wait, or send it to a person who is sure. Don't sit on the child unnecessarily. If you are not operating, what do? You patch the eye alternately. That prevents the one eye becoming dominant and the other eye becoming weaker and amblyopia setting in. Okay? Now, if there is amblyopia, treat the amblyopia. If there is refractive error, do a good cycloplegic refraction and treat the refractive error, because squint has got a lot of effects. Refractive error has got a lot of effects on squint, and squint itself can induce myopia. I have seen 3 or 4 patients where significant degree of intermittent divergent squint they had, and they had some amount of myopia, and they used the accommodative convergence to hold the squint in place, resulting in their myopia going up to -6. They had only -2 myopia, and they had -6 myopia. The moment you give -6, he has severe headache. He has got accommodative asthenopia, and also he has got muscular asthenopia. But if you take out the glass, he cannot see anything. And everybody was confused. I don't know what is the problem. I said, it's very simple. Put cycloplegic and diagnose. He has 70 prisms of exotropia. You understand? That is the effect of squint on refractive error. Not only refractive error has an effect on squint, but the squint has an effect in refractive error. That also you must remember. Okay? Now, measure the deviation in up and down gazes because AV phenomenon is very common. Up to 64% have AV phenomenon, which may need or which may not need treatment, but they do have, which needs to be recognized. Now, look for the presence of oblique overaction and underaction, and which, if necessary, needs to be treated because oblique overaction, if it's not treated, your squint comes back. Promptly comes back within 10 days, and you start wondering, what did I do wrong? Okay? Now, these are some of the figures which you can see, and the fundus examination is essential to look for many things. Apart from that, you can diagnose torsion. Okay? Now, have I finished my 10 minutes?
You have 5 more.
10 minutes you finished, no?
10.
Good. Okay. These are all some of the things which you need to look for, head posture, etc. in squint. Presence of head posture in patients with squint may indicate one, paralytic squint. But not all head postures are due to paralytic squints. Some head postures are due to restrictive strabismus in Duane syndrome, number 1. Some head postures are due to AV phenomenon, number 2. Besides that, head posture is also present when one eye is highly amblyopic. You get head posture. For example, left eye is amblyopic, highly amblyopic. Then what the child does is, holds the head like this, pushes the eye, this eye towards the nose, okay, where it is stable. Now, why the eye towards the nose is stable? Because of the early onset of nasal crossover, early onset of temporal fibers, the uncrossed temporal fibers before the nasal fibers phylogenetically. That's a different topic altogether, but it has some meaning in the... Now, routine recession of the squint is not the answer for squint. You need to operate on all muscles. I have not done only recession of lateral and medial rectus alone for a long time. I have given up doing that. Either I know too much or I don't know anything. Okay. Now, that is, in summary for you, strabismus surgery in children. Now, to summarize today's talks, they are all wonderful people, well known in their field. I don't need to tell anything about pediatric cataracts, which Sudarshan showed. Fantastic videos. I'm praising him more, not because he is from RP Center, but he has done a good job. Okay? So, if you want any videos which he has shown today, please write to us. We'll get all the videos for you. Is that okay, Sudarshan?
Absolutely fine.
Good. Now, Anil, unfortunately or fortunately, this guy is also from RP Center, so I have to praise him and his work and RP Center. What can I do? It's not my fault. Okay. He has done a wonderful job. His videos, I have watched his videos. Superb. That guy operates with passion. Okay. He has compassion because he treats children, and he has passion because he wants to work. So please, his videos are available. Anand is another guy. He's from PGI, unfortunately. PGI, but great guy. These two institutes, PGI and RP Center, were there long before any of the other centers were there. And he committed himself to retinopathy of prematurity. He went to Mangat Dogra, right? Said, I want to do only ROP work. Is that what you said after your PG? And he said, they have formed a society. We will try and affiliate you soon in AIOS if you send all the details. Now, Subhadra, she is from... I know. That's what I was going to tell you. Unfortunately, she is also from PGA. So, you see what it means. Only top institutes who were there top before. Now, we give a good run for money. Shankar Netralaya is there. LVPA is there. Hundreds of... Meenakshi was from Shankar Netralaya. Okay? Hundreds of institutes are there all over India. I am very proud that they are giving a good run for money for these great institutes, because that will keep them on their toes. The pediatric ophthalmology session was designed by me today, keeping this fact in mind that you should get the best out of all, and I'm glad if you have received it, please write to me, we will hold it.
We still have 5 minutes. I wanted to run 1 minute video.
No problem. We'll give you. Okay. So she wants to run 1 minute video, and you can give your concluding talk about your PGI also.
I want to say that I have learned from many, many institutes. Although I am from PGI, but I have learned from many institutes, right from Kashmir to Kanyakumari, and I have learned from students, I have learned from nurses, and I have learned from stalwarts. We'll just run a small video अपनी राष्ट्रभाषा के लिए. Can you please run the video? Start से run करें. It's only a 1 minute video. Lights. हमारे देश में बहुत सारे बच्चे 7वें या 8वें महीने में ही पैदा हो जाते हैं और आजकल बहुत अच्छी दवाइयों से, हॉस्पिटल, NICU से इन बच्चों की जान बच जाती है. लेकिन ये बच्चे 2-3 महीने के अंदर अंदर अंधे हो जाते हैं और इसका कारण है एक बीमारी जिसको हम रेटिनोपैथी ऑफ प्रीमेच्योरिटी बोलते हैं, यानी कि ROP बोलते हैं. ROP से बचने के लिए क्या जरूरी है माँ बाप को जानना कि बच्चे की आंख और उसके अंदर का रेटिना, जो कि पीछे का पर्दा होता है, उसकी जांच 30 दिन के अंदर अंदर हो जानी चाहिए. अगर इसमें कोई भी लापरवाही हुई या ये जल्दी से जल्दी चेकअप नहीं हुआ तो बाद में इसका इलाज नहीं होता है. 20 से 30 दिन के अंदर अंदर अपने प्री टर्म बेबी की आंख जरूर एक स्पेशलिस्ट से चेक करवाएं और अगर उसमें कोई नुकसान दिख रहा है तो उसका फौरन लेजर ट्रीटमेंट कराएं. और चेकअप के बाद भी जरूरी है कि हर हफ्ता 10 दिन में इस आंख का जांच करते रहना है जब तक कि आंख अंदर से पूरी ना बन जाए. अगर आंख का इलाज समय पे नहीं हुआ और वो आंख अंधी हो गई, बाद में उसका कहीं भी दुनिया में कोई इलाज नहीं होता है. इसलिए हर प्रीटर्म बच्चे की आंख जरूर 20 से 30 दिन के अंदर अंदर चेक कराएं. 30 दिन रोशनी के याद रखिए. Thank you so much. So I just wanted to conclude by saying that for all these speakers and all the material that we have, we don't have any copyright. Please feel free to take it, put your label on it and use it. There's a lot of material on our websites, on Anand's websites, on other people's videos, on YouTube. There's a lot of material on YouTube. Please use it for taking care of the eyes of your children and your friends' children and your great-grandchildren and grandchildren. Thank you.
Thank you very much. On behalf of the chairman, I'd really like to thank all of you all for attending this national symposium, and thank you AIS for giving childhood blindness such an important topic in the national symposium. Thank you very much.